Good afternoon again. Thanks for being here this afternoon. It's good to be here with you again today.
I'll catch you later.
The topic for our next hour or so is the trauma-informed guardian ad litem. And just like you, I serve as guardian ad litem in 2 counties, in my case in Preston and Monongalia County. And in preparation for this talk, I counted up how many children I currently have right now. And unfortunately, that number is about 70 children in 2 counties, which seems a little overwhelming when you really start to look at those numbers. And I asked myself, out of those approximately 70 children, how many of my children that I represent have some type of trauma? And unfortunately, I think the answer is that an overwhelming majority of these children suffer from some type of trauma. And what is trauma? When you look at the original word, trauma is actually a Greek word for wounding. And whenever we have a wound, a scar tissue forms, and that scar tissue is always harder, less resilient, and less flexible than the tissue it replaces. So I like this idea of thinking about trauma as a wound, and though it may heal to some extent, we always have a part of that with us. There's always going to be a scar, and I think that that's how our children, unfortunately, who have been exposed to trauma, that's unfortunately how they're going to live their lives. But I believe that we as guardian ad litems can make them stronger, and that there's no more important work in any field, I believe, than what we do as guardian ad litems, because nothing really changes a person's life hardly more than what we do. Either they're reunified with their family, or in some cases they may never see members of their family again. So I applaud you all for the hard work that I know each of us do every day throughout our state. We're going to talk about what are the types of childhood trauma.
Excuse me, no stance.
And according to the National Child Traumatic Stress Network, there is a range of traumatic events or trauma types to which children and adolescents can be exposed to. And those are bullying, community violence, complex trauma, disasters, domestic violence, early childhood trauma, medical trauma, physical abuse, refugee trauma, sexual abuse, terrorism and violence, and traumatic grief. Most of our children from that list suffer from complex trauma. And what is complex trauma? Complex trauma is defined as children's exposure to multiple traumatic events, often as an invasive interpersonal nature, and the wide-ranging long-term effects of this exposure. These events are severe and pervasive, such as profound abuse or neglect. They usually occur early in life and can disrupt many aspects of the child's development and the formation of a sense of self. Since these events often occur with a caregiver, they interfere with the child's ability to perform a secure attachment. Many aspects of a child's healthy physical and mental development rely on this primary source of safety and stability. I think it's easy to fall into the trap that once we remove a child from the trauma, then everything is going to be okay. And I know that early in my practice, I really used to think that, like, oh, if we only love this child enough, now that we have them away from this trauma, everything is going to be okay. And I think that we all probably know that that's unfortunately not the case. When we look through the definition of complex trauma, one portion that really jumps out at me is the child's ability to form a secure attachment has been interfered with because the events of abuse and neglect occurred with a caregiver. So how can we, as guardian ad litems, help a child with their inability to form a secure attachment? How do we build a relationship with a child who has trouble trusting adults? We're going to talk about a few ways that I think that we can help a child form that ability to a secure attachment, and I'm hoping that some of you can share ways that you've also done that. I think the first and foremost, be a model of positive adult relationship to a child. I think because in our life away from work, we probably have a lot of experiences where children see adults being positive, where children see adults being good role models. Unfortunately, many of our children in abuse and neglect cases are not so lucky. They have not seen adults working together for their benefit on a regular basis. Some of the things that I think it consists of, and I may be the only one who does this, but sometimes when I go visit a child for the first time, I almost treat them as if I'm meeting an adult. I will extend my hand and shake their hand and introduce myself and make eye contact with them. And I think that gives them a sense of, yes, this is a very important meeting, and she's very interested in making sure that I know who she is and she knows who I am. And so I would encourage you to invite them, introduce yourself in some kind of way that's friendly and inviting and makes them feel that this is an important meeting. I try to make sure that I keep my eye contact with them throughout the meeting, that I'm not distracted. I think we're so used to looking at our phone and our computer and our Apple Watches all the time, and I really try to put those things away during my meeting with children. I try to take time with the child to ask them, how is school? What kind of activities do you like to do outside of school? I try to get to know them outside of this context of just an abuse and neglect. I ask them if there's anything that they need. Is there anything from home, an item that they're really missing? Is there anything that I can get you that would make you feel more secure? I have a little girl right now that I represent. Her name is Lauren. And when I asked her that question, it was because she was having trouble sleeping at night. And she said, well, I'd really like to have some kind of soft pillow. And she loves pillows and she loves unicorns. And so I just got her online and ordered her a unicorn pillow, and I shipped it to the foster care home. And we later had to move this child to another foster care home. And the first time that I went into the new home, I saw that she still had that unicorn pillow from many months earlier on her bed. And she told me that helps her sleep at night. And so I would encourage you to find if there's something special that would make them feel more secure, please feel free to try to get that for them. Let the child know that you can contact them, and when they call you, this sounds obvious, but answer your phone. If the child is school age, I tell the child, I've left my cell phone number with the school secretary or the counselor or their teacher. If you'd like to speak with me, all you have to do is go to the office and the secretary will be able to get in contact with me. If I don't answer your call that day, I will call you back as soon as possible. And more often than not, children do call me 1 or 2 times from school. I think that's a good way for them to know that they're special and important and that they can get a hold of me. They don't have to wait for me to come visit them to have the opportunity to speak with them. And allow your child to see you interact with other adults positively for them. So I usually go to their therapy appointments or I go speak with their teacher. And I think it's really important that they see you working with other adults for their benefit, because they more likely than not have not seen that in their prior life. Second, be a source of resilience for that child. And how is resilience defined? Resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. This is not a trait that an individual either has or does not have, but it does involve behaviors, thoughts, and actions that can be learned and developed in anyone. How can we help a child build resilience? If the child is having trouble, for example, with a subject in school, I try to teach my child, this is how you go to ask for help from the teacher. The teacher will be willing to help you, and you will see a positive result. A lot of times our children don't know how to ask their teacher for help. And so the first time, I often have done that with them. And I think that helps them build resilience, that if I'm having a problem, I can make adaptions, I can ask for help, and I can see a positive result from that. I'm probably slightly more fortunate than you are in helping children learn resilience. I was born with a brittle bone disease called osteogenesis imperfecta. My bones break very easily, and I wear leg braces. And so every single child that I've ever represented in the past decade always asks, why do you wear leg braces? I know that it's coming within the first 30 minutes. And that's fine, and I show them my braces, and they can touch them if they want to. They always have a million questions about it. But I try to take it as a lesson to say, even though I was given this hand in life, I was able to adapt, I was able to find resilience and still find success and happiness in life. And a lot of kids look at me with kind of an aha moment because they realize that, well, she had something that was hard and she was still successful, and I can do that too. I think it's important that we share a little bit of ourselves with children when we're representing them, especially on the harder cases. And you might not have quite as easy as an example as I have with kids, but I'm sure that you have something just as compelling to share with them that they will remember. Third, in regards to helping children form a secure attachment, remember that you may be the only consistent adult in the child's life. How many of you have had abuse and neglect cases that have lasted more than, let's say, 3 years? Yeah, more than 5 years? I probably don't look it, but I'm actually getting old enough where I've had cases that lasted longer than the prosecutor or the other attorney I'm practicing with, which is kind of a new thing for me. But as you know, these cases tend to go on and on. And we had a very sad case in a county where I practiced at. There was a little boy named Will, and Will had been in the system since he was 7 years old. When I first met Will, he was 12. And during those 5 years, he had had multiple guardian ad litemers. He'd also had multiple department workers, he had been in multiple schools, and he had been in multiple placements. And we found out that over a 5-year period, he did not know one guardian ad litem's name because no one had ever visited him, except maybe once we gleaned from the records, and he could not remember that person's name. So because no one ever visited him, no one ever saw how he was doing, he simply got lost into the system, and he was moved around from placement to placement to placement in the state of West Virginia. And a friend of mine was appointed guardian ad litem to him. And he started to visit this child, and he started to take this child to dinner. And then he started inviting this child to meet his children. And then he started inviting this child to meet other people in the family. And then all of a sudden I was appointed guardian ad litem because he couldn't be guardian ad litem anymore because he had decided to adopt this child. And during the course of the case, which the only way that he was ever going to be adopted is because some adult took an interest in him. During the course of the case, he was telling me that they were out to dinner with his biological children and Will and his wife, and this older man held a door for him and he said, my son, you surely have a beautiful family. Look at those beautiful boys. And this old man thought that this child was in fact also his biological child. So magical things can happen when we take an interest in a child, and I surely hope that we'll be the ones in the state that will stop a child from never being visited for 5 years so that they don't end up just stuck in the system in placement. So be a consistent adult in a child's life, be a source of resilience, and be a model of a positive adult relationship. But leave it to the therapist to dig in deep to the levels of the layers of trauma. I don't think that being necessarily a good model and being consistent really means that we question our children intensely on the trauma that's happened to him or her. That's really best left to a professional. And I see sometimes in cases where we have all these people questioning children, and I don't understand it because I wait for these children to tell me about the trauma that they've experienced. My job, I believe, is to be there for them on a consistent basis and make sure that they're getting all of the mental and educational and physical health services that they need throughout the process. Do any of you have tips that you want to share about how you help kids create secure attachments with adults? It's been a long couple of days. Everybody's quiet. Okay. We're going to talk a little bit about talking to a child with complex trauma, and I know this has been touched on earlier today. But we need to remember that the more complex the trauma, the more distortion of thought that the child will experience than children who have trauma that have not. So kids with trauma have more distortion of thought than kids without trauma. I hear attorneys all the time say in the hallway, well, my 10-year-old loves to do X, Y, and Z, so surely this 10-year-old will love to do that too, or my 5-year-old acts this way when this happens. So surely the 5-year-old in this case will react the same way. And that's just not a realistic outcome because your child maybe has not experienced trauma. They don't have the distortion of thought that unfortunately our children have. So we have to remember that our kids don't maybe think as clearly as they should for their age, and that their emotional age is probably younger than their actual chronological age. So what do you say when you first meet with a child? First, I always do that getting to know you time that I described earlier. And then somewhere I just say something like, do you know why we're meeting? Do you know why you were in foster care? And are you comfortable talking about it? And if they tell me no, they're not comfortable talking about it, I just change topics, because we can let the therapist do that, or we can do that another day when they feel a little more comfortable. One thing you have to remember though is children with trauma are great keepers of family secrets. They will go to great extent to lie for their parents or to lie for family members because they think they have to protect them. And I had a child that was just brutally abused in one of my cases. There was a CPS worker that first investigated that had been with the department about 30 years, and he said that he never had a case worse than this one. The dad actually, one of many things, there was a broomstick in the house, and he put the child like a scarecrow over the broomstick. I still get emotional thinking about it because she's such a beautiful child. And he broke her arms on that broomstick. And she had been life flighted several times, and it was just horrific. And this child, I never really asked her about it, but I had been to see her in foster care, and I had been to see her at school, and I had been to therapy, and I just kind of kept showing up. And she was acting kind of poorly at school, I'm sure due to her trauma, and she wasn't doing the things that we felt she was capable of, even with her level of trauma. And so I probably inappropriately went to school and kind of got on her, like, you know, you need to do better. I believe you could do better. What can I do to help you? And I was kind of scolding her, probably like against every textbook that we have. And in the midst of that, she blurted out, you know, my dad hurt me. All of the stories were fake. He broke my bones. He threw me down. He sexually abused me. And she said it just like that as a 4th grader. And I thought to myself, I must have been one of the first people that actually cared if she ever did well in school, or if her grades were good, or whether she was behaving appropriately, because somehow, some way, me caring about that and probably inappropriately yelling at her about her behavior at school led her to feel safe, and it led her to tell me what horrific trauma had happened to her. Do any of you have any suggestions about talking to kiddos that you want to share? No? This is like a quiet group. Okay. There's nothing scarier, by the way, than talking to a room full of attorneys. Okay. Hard topics. Collaborate with the child's therapist to talk about hard topics. I'm always just kind of horrified that some of my colleagues try to like take on these like hard topics all by themselves. I'm currently in a case, I represent one of the adults, but literally this child is like questioned by like CASA and the therapist and the guardian ad litem and the school and like anybody and everybody, all at different times, all at multiple times a week. And if I was guardian ad litem, I literally would like shout and scream at them and say, you know, maybe this should only be the therapist, and we really need to let the therapist do this. And if you really feel a need to be there and be involved, then we need to do this all together in one session so that this child is not questioned multiple times. And if there's anything that's like a takeaway from what I'm saying is, don't let your children be questioned multiple times by multiple entities. It's really important to try to limit that and to let the therapist discuss hard topics. That's what they're trained for. I'm not trained to do that. You're not trained to do that unless you have a degree in counseling. And so I think it's important to just kind of put your foot down with the department, put your foot down with CASA, put your foot down with the school and say the therapist is running this show about digging in deep with the child about their trauma and enforce that. I think that's one of the best things that you can do for a child with trauma. One story that I have about talking though with children like with hard topics is, like I said, I usually like to work with the therapist to do that. I just feel more comfortable, and I think it's good again for the kids to see adults just working together for their benefit. And my little kid who really likes unicorn pillows, Lauren, she was in like an idyllic foster home and you know, in a nice suburban neighborhood. The family had money, it all looked great. And we slowly kind of figured out that she actually was probably being somewhat abused in the foster home. And we realized that we needed to move her pretty immediately. And so I did all this research, searching out like the perfect foster care home for her. And it was kind of funny because one of the choices was a school teacher in Morgantown, and some kids that I know actually have this person for school as their teacher. And I even interviewed those children to like find out, you know, is this person okay? Because who better than to look some other elementary school children to tell you if somebody's a legit person. And I went to great lengths to like make sure that this transition was going to be okay and this new foster parent, and I was like really proud of myself that me and the therapist got together and had this elaborate plan for how we were going to tell this little girl, you know, I know you've been removed from your parents, but now you're going to be removed from your foster care home into a new foster home, all within the span of about 5 weeks. And the therapist and I were like ready to go, and we even did a practice round, and we brought her in, and she just looked at me and she said, well, can I meet them? And I was like, well, sure. And they were like down the hall, and they came in, and then about 3 minutes later, she's like, well, I'm ready to go. Can I just go with them? Can we just like cut this off? And I was like, sure. So sometimes you also have to kind of like throw your ego out the window, because sometimes kids are pretty resilient, and you know, the best plans that you have for discussing hard topics with them, sometimes they can kind of throw that out the window and just be ready to go. So I think it's better to be over-prepared, obviously, than under-prepared. So we're going to talk a little bit about behaviors for a child with complex trauma. I know that something that I run into, and I know that you run into, is we get to a lot of questions from foster care and the school about, well, this kid's doing this and this kid's doing that, and they kind of seem like a bad kid maybe, but it's really to do with their trauma. They're not bad children at home, and I feel like I'm kind of always constantly just kind of fielding those questions from foster parents and the school, and trying to just let people know, like, this behavior is caused by the trauma. They're actually a really good kid. So the National Child Traumatic Stress Network tells us that a child with complex trauma may be easily triggered or set off and is more likely to react very intensely, struggle with self-regulation and lack impulse control, lack the ability to think through consequences before acting. How often does that happen? Seem spacey, detached, distant, or out of touch with reality. Be more likely to engage in high-risk behaviors such as self-harm, unsafe sexual practices, and exercise excessive risk-taking. Sometimes, especially if the child is maybe elementary school age, I think foster parent and the school might rush to say, hey, you know what, this kid just has ADHD. It's not trauma, because it's like easier to wrap your head around ADHD than trauma, right? And I had one case where the foster parent was so insistent that the child immediately be put on medication. Oh, this child must have ADHD. I know that this is like a big debate in the counseling community, but I think it's important that before a child is evaluated for ADHD, we need to try to make sure that their environment is stable, that it's loving, that they have a routine, and that they know that they're safe. Because only then are we going to really see what their true behaviors are. And only then are we going to have accurate reporting from their teachers and their foster parent about what their behavior really is. And so I always tell people, like, we really need to give this a couple of months. And then at that point, if they're still exhibiting these behaviors, then absolutely, let's get them evaluated for ADHD. I really like this chart. It kind of helps me. And it shows that trauma has some, symptoms, and ADHD has some symptoms. But in the middle, there's this overlap. And I think that the overlap obviously is what confuses people about, is this trauma, is this ADHD? And the overlap is difficult concentrating and learning in school, easily distracted, often doesn't seem to listen, disorganization, hyperactive, restless, and difficulty sleeping. And I did not make this graph, so I cannot take credit for it, but I think that this is a really helpful graph for you to kind of keep with you. And when people start asking you, like, hey, I think this kid has ADHD, and you're saying, well, I think maybe it might be trauma or it might be both, that this is a good place to start kind of analyzing what their behaviors are. Yes?
Max, what is the source of the graph?
I actually can't remember offhand, but if you do a Google search of trauma and ADHD, this is going to come up in like 1,000 different places. It's all over. Sure. And then I'm sure, like you, I have some key people in Morgantown that I use to evaluate a child with ADHD. And I always try to collect all of the child's medical records ahead of time and make sure that we have a good account from the school, as well as the foster parent, to try to make sure that we have accurate reporting for that child. Because putting a kid on ADHD medications, if they need that, it can change a child forever, and you just want to make sure that they need that before you do it. New slide. Thinking and learning for children with complex trauma. Children with complex trauma may have difficulty thinking clearly, reasoning, problem solving, learning new skills, remaining focused due to reactions of trauma reminders, developing language, and abstract reasoning skills. So what does this mean for us as guardian ad litems? It means that we need to be really involved in the academic setting. My belief is that as guardian ad litem, a big part of our role is working with the school. I'm currently in a case where we had the school testify recently, the counselor, the assistant principal, and the teacher. And thank goodness I'm not the guardian ad litem in this case. They got up on the stand and they said, we had no idea who had custody of this child. We had no idea who really had placement. We had no idea who really the decision maker was, because nobody from the department or the guardian ever gave us an order or came to the school to tell us that. And that just really blew my mind. Like, how do you know who can even pick this child up? And if you have a child with complex trauma, doesn't it help that child to know that the abuser, mom, dad, aunt, uncle, neighbor, can't come to the school and pick them up? That just blows my mind. And the school, and it was a prominent school in Morgantown, the school was begging on the stand, please, please, somebody from the Department of the Guardian ad litem needs to come to the school and let us know who has custody of this child. So I think that, our department workers are really just overwhelmed. We as guardian ad litems need to contact the school. I make it easier on myself. I just have a habit of taking my appointment order only. I send it to the school and ask for their records, and I ask them to note that this is the custody schedule. That way I know that it's done, and that I do it within the first couple of days so that it doesn't get lost. It takes me, 10 minutes to do that, and then that way the school knows. Don't expect or anticipate that the department is going to take care of that for you. And one of the first things that I go over with my kids is, hey, only, people A, B, and C can pick you up from school. If anybody else tries to pick you up from school, do not go with them. And that's a very important conversation to have with all of our children. The other thing I like about sending that letter to the school is then I get back and return their attendance records, so I know if they went to school. My kiddo Lauren with the unicorn pillow, she had missed 50 days of kindergarten and 50 days of first grade. So no wonder she was so far behind. 100 days in 2 years, it's mind-blowing. No wonder she was so far behind. I get that, I get their disciplinary records, and it tells me whether they have an IEP or not, which is really helpful information for very little work. One thing I really like about practicing in a rural county instead of like Monongalia County is that the secretaries at the rural county, they're like the guards keeper. Like, they have all the good information. They have all the secrets, they have all the gossip, they have all the really good information about our children. There's one elementary school really close to our courthouse in Preston County where when I go see a child, the secretary always makes time for me when I'm there to let me know how that child is doing and how all of my other children there are doing. And she also reaches out to their teacher and lets the assistant principal and the principal know that I've been there, that I'm involved in the case, and if they have any information, to please let me know. It's really important to make a good bond with that school secretary because that is really the link to so much information, and it's really helpful. Next, we're going to talk a little bit about emotional responses in kids with complex trauma. And our children often experience difficulty identifying, expressing, and managing emotions. They have limited language tools to express their feeling states. They internalize and or externalize stress reactions, and they have emotional responses that may be unpredictable or explosive. I love this graph. So it's from the Gottman Institute. It's also all over online. And so oftentimes with our kids, what we see is anger, right? We see lots and lots of anger. And I like this iceberg graph, and maybe some of you have seen it before, but it tells us that we can only see one piece of an iceberg, right? Like, that's what's floating on the surface, and that's what the eye sees. But there's so much more underneath the water that we can't see. And I like this graph because I think this describes a lot of our children. All of those emotions that are in the bottom of the graph is really what they're feeling. They're feeling embarrassed and trapped and rejected and nervous and exhausted and disappointed and hurt and regretful and worried. And how does that come out? That comes out as anger. And I think that this is also something good to kind of talk to your foster parents about when they're just feeling overwhelmed with a child who's showing very kind of angry tendencies. I think on an alternative spectrum, a lot of our kids just tune out. They're just like emotionally numb. They just totally tuned out. And those kids make me nervous sometimes because I'm always worried that they're going to be re-victimized in some way because they are so tuned out. So just trying to help them kind of tune in and speak up and know that they can talk to trusted adults in their life. We're going to actually watch a video. I felt like this was cheating, like showing a long video in my talk, but I really love this video, and this is kind of a new topic for me. Hopefully it's not a new topic for you. It's about the long-term health consequences of childhood trauma, and I think that this opens up a whole new world that we really need to explore, in that we need to make sure that we're also taking care of their mental health as well as their physical health. I at least am guilty of kind of putting their physical health on the back burner. I mean, I may make sure that they have dental work, or that they have glasses, or that they, have like a pediatrician checkup appointment, but it's a lot deeper than that. And in preparation for this talk, I asked 5 counselors that I'm close with, what kind of things do you want guardian ad litems to know about our children who have trauma? And one of them, who runs our CASA in Mon County, said she thought every guardian ad litem needed to watch this video. So we're going to take a few minutes and watch this video, and I hope that you find it as helpful as I did.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on. You know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, It is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, your multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask, how many people in this room grew up with a family member who suffered from mental illness? I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across a lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer, will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real and this is all of us. I believe that we are the movement. Thank you.
So when I saw that and I was thinking about it in preparation for this, I think there's some points to that really change maybe how we're guarding litem. At least it changes to me. It makes changes for me. When I watch that, I think to myself, maybe we're too slow to get children mental health services in a case. Maybe we think that it can wait until after adjudication. And my first thought is, obviously it can't wait. Obviously this has to be done immediately. My second thought is, I really need to make sure that they have a good pediatrician and that pediatrician needs to be involved in the case. And that pediatrician maybe even needs to be part of the MDT so that we can make sure that this child is as healthy as possible. Did any of you have any thoughts from watching this? Maybe some of you have seen it. It's a few years old, but this was new information to me. No? Okay. Oh, yes, Rachel. Sorry.
Hi. I don't know if you've had a chance to take a look at some of the resilience videos. There are several responses to the ACEs that they focus on encouraging resilience factors. And I think those are also very helpful when we're trying to help a child get appropriate treatment. And because it's empowering, and I think it can really give us the directions to go when we're trying to figure out what kinds of services to seek for a child.
Absolutely. So what Rachel just shared with us is that in response to the ACEs study, there's been a number of resilience type based thought processes in teaching children to be resilient. And I agree with you completely that some of the things that overcome trauma they can find within, correct? That we can teach them to build some of those skills within themselves so that they can learn to adapt. Is there anything else? Okay. One thing that I did in preparation from this was I talked to a few of my counselors that I use on a regular basis, and I wanted to share with you what they wanted you to know. The first is Dr. Tracy Berry Harris. She practices at Fremont Sigley Psychological Associates in Morgantown. And she wants you to know that, remember that it can take a child months before they open up, and don't rush that process or get frustrated by it. There's nothing wrong if it takes a child 6 months sometime to open up and tell you about the trauma. She thinks it's really important that we visit kids at school because she sees school as a really safe environment for children. And she also thought it was really important for attorneys to become familiar with the DSM-5 and to know what some of those diagnoses were, even if you just spend a couple hours going through that, and even at an amateur level basis. I also talked with Sharon McMillan. She's a psychologist in Kingwood, West Virginia. She wants you to know that developing a trusting, we are in this together for the kids' teamwork is extremely important. She also wanted you to know that it's really important for the therapist to have a guardian ad litem who's constantly in contact with them, so that if you visited a child at school or at home, that you report back to the therapist about what you saw, and that likewise, when a child comes to a therapy session, that she reports to the guardian ad litem what she saw. She believes that it's important that both the guardian and the therapist work together to verify information that a child is providing them as part of the healing process. And she actually emails me sometimes multiple times a week, and I think to myself, wow, this is a lot. She'll send me novels. But really, that's the kind of therapist that we want. We want a therapist who's so vested in our children that they take the time to send you an update every week. And if they're not doing that, probably if you ask them, they would be willing to do that on a weekly or bi-weekly basis. I also talked to Charlene Vincent, who's a therapist at Resilient Kids in Morgantown, and she said that she really appreciates it when a guardian ad litem will come to a session and talk with kids about hard legal issues. She said that she really doesn't feel comfortable explaining to kids what a termination of rights is, or are they going to be in a guardianship, or are they going to be adopted. She says that she really thinks that's best done by the attorney, but she also thinks it's best done in the environment of therapy. She also wants guardian ad litems to know that she appreciates guardian ad litems who want to hear from her about why a kid is presenting behaviors in a way that they are, and that they're not just simply acting bad or acting out, and that she appreciates a guardian ad litem who will take her thoughts and then also share those thoughts with the pediatrician and with the school. Ms. Vincent did something recently that I really liked for one of my kids. I'm always the one kind of setting up their psychological evaluation if they need it, their educational evaluation, their ADHD evaluation, whatever kind of evaluation we might need. And Ms. Vincent did that for me recently. She made the referral, she talked to the provider, she got the billing information, and she gave them the report. And I thought, wow, that's really fantastic. That first she talked with me, she talked with the foster provider, she talked with the child's teacher, and then she made the referral and provided the person who's going to do the evaluation with that information. And then she sent out an email and she copied everyone on the case in that email and said to the provider, these people may be reaching out to you with more information. And I thought that, wow, that's something that maybe we should start doing on a regular basis. This morning, after I talked about improvement periods, one of our colleagues from, I believe he's from Mingo County, asked a question. I thought this was a really good question, and it goes with this topic, I think, of trauma. What do you do if there are no service providers in your area? That's not a problem that I run into too much because we're so close to Morgantown, even cases that I have on a rural basis. But I think that this is a really good question, maybe for us to discuss as a group. What do we do if there's no service providers? Kind of my instant answer off the top of my head is, because I run into this a lot where I live, is a lot of our providers won't take the medical card. And it's not because they won't be paid by the medical rate. It's because they don't want to be regulated in the way that Medicaid in West Virginia regulates it. They don't want their files reviewed. They don't want to have to practice under the Medicaid regulations that has nothing to do with the rate. And I've been very successful in our area. If there's a therapist that I really want to use, Ms. Vincent that I talked about at Resilient Kids is one of those therapists. They were willing to do a discounted rate for me, for our kids. Not only were they willing, they were happy to do it, and they said that they would take as many children from our abuse and neglect cases as they could fit in a discounted rate. All I had to do was make a motion with the court, which I did, and said this is why I think this therapist would be best, because we are limited by the number of therapists sometimes who will take the medical card, at least in my area. And I made that motion, I made the order, and the judge happily signed off on it because I thought that this was the best provider for my children. I think that a lot of us probably have judges that are willing to work with us on that, and the department was also okay with it because it was only slightly above the regular rate that I was able to contract with them. So that's one idea. Another idea I had is that I know that Ms. McMillan in Kingwood has children who live in very rural areas, and they may live up a mountain. And you know, in West Virginia, when it snows, you may not be able to get off that mountain to get them to therapy. Well, she can do it through video, and she can do it through computer. She has a special program for that that's HIPAA compliant. I think that if we ask around, a lot of our providers in West Virginia might be willing to do that, and maybe we can transport those kids. I know it seems like a long way, but we may have to transport them an hour or an hour and a half once or twice a month, and ask the department to take care of that, and then see the therapist in person once or twice a month, and then see the therapist every other week, or 2 weeks, by video, or 2 weeks by video, 1 week in person. I think based on the ACEs study, based on the video we watched, it's certainly worth transporting a child 1 to 2 hours for mental health care. We do it for visitation every day in the state of West Virginia. We make our children, unfortunately, travel a long way for visitation. But maybe we haven't thought about doing that for mental health care or for medical care. And I think that that's something that we need to start insisting that the department does for us. And I think that we're going to find that both the department and the judges are willing to do it if we lay the groundwork for it. I think my other idea at that really good question is, if you have enough children, if you have a full day's worth of children, if you have 8 to 12 children in your county, you might find that a provider from Morgantown, from Parkersburg, from Clarksburg, from Beckley may actually come to you for the day if they know that they're going to have a full day's work in your county. And you might find that, the local school or the courthouse or your office, or you can find somewhere that will host that person. And if you can provide a full day of work for them, maybe that they'll come to you. Does anybody else have thoughts about that question? I think that's a great question that I hadn't thought of. You all are super quiet. Okay. Are there any other ideas about trauma? Yes.
No, I just wanted to relay a story that I actually have a case right now where the child was originally diagnosed with ADHD and was on medication, but then started counseling, and after about 4 or 5 months in counseling, he asked his pediatrician if he could go off the medication because he didn't need it anymore. And so they did a test run, and he did fine without the ADHD medication. And his therapist had said that she thought it was trauma-based behavior and not ADHD. So the point you made earlier is something that I've actually experienced in the case. I just wanted to bring that up.
No, I appreciate that, Mr. Gutman. So he's, just in case you couldn't hear him, he's talking about how he has absolutely experienced that a child was on ADHD medication, but then later the child, if I'm relaying the story right, I don't think I'm in that case with you, realized that they didn't maybe really need this medication, and it was discovered that his behaviors, his or her behaviors, his or her how he was reacting to the world was based on trauma and not ADHD. Is there anything else? No? Yes?
Are you practicing by yourself?
Yes, so I am in a firm with one other attorney, but he does not practice abuse and neglect, so I'm by myself in the abuse and neglect world, yes.
I just wonder, you're providing a really high level of service, it sounds like, and I wonder how many cases you feel you're comfortable with having.
So I feel that I have too many cases right now. I would readily tell everyone that. If you ask my mother, she would tell you that I work an obscene number of hours. I probably work 12 to 14 hours, 5, 6, sometimes 7 days a week right now, because we have such an incredible volume, especially coming out of Preston County, that I'm assigned to. And I think sometimes it's easy to get kind of a secondary trauma from that. And I think we have to be careful to take care of ourselves. I've found in the last few months that I have had to make sure that I was taking care of myself physically and emotionally to make sure that I can provide care to those children. And there's nothing shameful in realizing that you're kind of getting a secondary trauma from being around so much trauma year after year. after year. I think one thing that makes my job a little bit easier is I'm a little probably more fortunate than some people because there's a lot of resources in Montague County. And I've been able to make really good contacts and have the ability to text and call and Facebook and email a lot of really good therapists, and that makes my life substantially easier. So a lot of times, you know, while I'm waiting in court, I'm also texting that therapist and making plans. And I know early in my practice, I didn't have those kind of contacts, and until you can establish those contacts, I think it's hard to provide that level of services or in such a volume. And I mean, there's no, I certainly like prioritize some children over other children. And I hate saying that we do that, but I think we all do that. I mean, there's children who absolutely need us several days a week, and there's other children that, you know, are a little bit more stable in their environment, and I don't have to see them maybe quite as much. I don't know if that answers your question. A couple things that I've learned about handling kids is sometimes like things that I do for them that are the best things that I've ever done for a child have nothing to do with mental health services, have nothing to do with going to the doctor or school. We had a child, one thing that I do to kind of answer your question is I tend to kind of like want to put kids close to me, and so like we have a really pretty good shelter in Morgantown, and you know, I'll bug the shelter lady so that she'll take my kid because I live 5 minutes from it. It's very selfish from my part. I live 5 minutes from there, and so it's really easy for me to go visit that kid, and I can be there in 5 minutes. And this particular kid, I found out during the visit, had a really good singing voice, like really, really good singing voice. And I was a voice major in college. I sing, I play piano, and I thought, you know, like I should take this kid like for a voice lesson. And so I contacted my friend who's the choir director at W.Va, and I said, do you have any grad students that like I can pay to give this kid a voice lesson? And she said, yeah, I do. And the grad student would not let me pay them. She did it for free. And so I picked up the kid you know, one Tuesday night and took this kid to a voice lesson, and the kid has like a phenomenal voice. And the kid was crying when he got back into the car because he said, I found myself. I didn't know that I could sing like that. I didn't know that I had this talent. I didn't know I could do this. And so I took the kid to like a few more voice lessons, and we eventually reunified, and the kid is in the choir in the local high school, in the local county, and the kid's in all of the theater productions. And I think sometimes doing that little extra thing can change a child's life in ways that the courtroom maybe can't. I think the other thing I've learned is when I do something for a kid, it's not a reflection on me if they don't say thank you, or they don't express any appreciation. That used to kind of bother me. I had this one kid that I'd had for years, and I was like the only person who was sending him Christmas gifts, birthday gifts, stuff for school. You know, I'd always ask, and he would never tell me thank you. He would never send a thank you card. He never told me thank you on the phone. And I asked him about it one day, like, hey, why don't you say thank you to what I'm giving you? I don't know why I said that. I should have kept my mouth shut. But he looked at me and he said, was I supposed to? And I had to like stop myself and remind myself that I have to teach this child how to interact with the regular world, with adults. And so I taught him how to write a thank you note and how to call somebody on the phone and tell them thank you. And then every time after that, he would send me a thank you. And I think that's a life skill. So it's not a reflection on me, it's not a reflection on you when they don't say thank you, but we do it anyway, right? I mean, I spend like way too much of my income on children that I represent, and I'm sure that many of you do too, but they've never necessarily maybe had a special gift, a special item, a special anything. And sometimes we don't have the words, the right words to say, I care about you, I care if you're successful. Or maybe they're not comfortable having that conversation. But if I get them something, not that we want to teach them that it's all about tangible things, but if I get them something, if I deliver something to them, I know that I've done my best to teach them that I do care, and this is how you interact with other people in normal society. You do nice things for them, and you teach those children those skills. So it's not a reflection on you if they don't say thank you. Are there any other thoughts, suggestions? I really appreciate your attention. I've never spoken to a room full of attorneys before. I love abuse and neglect with all of my heart, and I probably put too much of my personal life into it, but it's really an honor to speak to you all, and I hope that I was able to offer something about your work with children, and I really applaud all of you for the hard work that we all do each and every day when serving our children. Thank you.